speaker?
No, sir. Dr. Viraj is there. I'm just informing.
Yeah, it's okay. Don't scare me, man.
Not at all, sir. Thank you, sir. So my screen is visible, right, operator?
Yeah.
Okay.
Sir, we are live now.
Good morning, doctors, and welcome to this webinar on a sun day. I have deliberately emphasized the word sun in Sunday because clearly today is a Sunday and the entire meeting is about vitamin D, as you can see on the slide, the Centurion Defender indicating 100 years of vitamin D. But today, what we'll be discussing, one is of course in general about vitamin D, but in particular about its role as far as immunity is concerned. Maybe a little bit on COVID-19, is there some kind of correlation? And then also a little bit about the dosing regimen, 1000 IU daily or 7000 IU weekly. And ever since this lockdown began, obviously we've not been going out often, and maybe our exposure to the sun has decreased. But even before COVID, how many of us were really going out between 10 a.m. and 3 p.m. because that's the best time? And even 30 minutes of sun exposure, were we really getting it? So then, of course, the next thing is, do we need to supplement our diet? Because the diet itself, unless fortified with vitamin D, may not be adequate. So ultimately, what we're going to discuss today is everything about vitamin D within this space of 1 hour. Initially, of course, we have two of, I would say, global, not just Indian experts as far as vitamin D is concerned. So they will let us know their thoughts. And then, of course, I may ask a few questions, but if I see that you all have already posted quite a few questions, I may straight away start asking both our experts your questions on vitamin D. So can I have the next slide, please? So first of all, I would like to briefly talk about Dr. Amrish Mittal. As all of us know, Padma Bhushan, Dr. B.C. Roy awardee, Chairman and Head of Endocrinology and Diabetes at the Max Healthcare, Max, so across the Max Healthcare group of hospitals. He was appointed domain expert on the governing board of the National Health Authority of India and president of AIIMS in Gorakhpur in 2019. He was the first DM in endocrinology from the All India Institute of Medical Sciences in 1987, subsequently served on the faculty at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow from 1988 to 1998.
Raj, I'm really sorry it's rude, but it's not required. Let's go ahead. Let's not waste valuable time on this, right? Thanks a lot. I'm sorry.
Yeah, no problem. No problem. Next
Viraj,
slide.
you can actually skip both our introductions because I think we are reasonably well known to everybody.
Okay, so I won't really talk too much about Dr. Shashank also, except to invite him to now take us through the presentation for today, after which I'll be inviting Dr. Amrish Mittal for his thoughts, his perspectives, and then of course we'll have the Q&A session. So over to you, Dr. Shashank. Thank you.
So thank you, Dr. Viraj, and I am really happy that you are thinking of vitamin D on a Sunday, and Sunday was actually a sunny day. And unfortunately, in Mumbai, where you and me are, it is pretty gloomy and monsoon-like, rains all over. And I'm sure with Dr. Amrish in the Rajdhani, these things are very similar. Can I have the slides, please? So, I'm just going to give a opening remark, and then, of course, we'll have Professor Mittal giving his comments on four things, which are vitamin D. And we know so much about vitamin D, but still, just a simplistic overview of vitamin D. We are living in a times of uncertainty. We are living in new normal, and immunity has suddenly become our focus again. It is very difficult to estimate and postulate, but there is clearly a link between the latitude and longitude where COVID is and the exposure of sunlight and the D levels. And there might be some interesting correlates which may come in. And I'm sure Dr. Mittal has some unpublished data. We have some unpublished data, which might be worth interesting to look at. But clearly, vitamin D and immunity has a strong, strong correlate. Then, of course, D and COVID-19 is the topic of the day. And we are here because what should be the vitamin D daily requirement? Should we give it once a day? Should we give it once a week? Should we give it once in a month? Should we give it once a year? Should we fortify our foods? I mean, that's the interesting thing. And Dr. Viraj, you are a clinical pharmacologist. You happen to be my batchmate. And, I'm sure you will have your own pearls of wisdom on the pharmacology of vitamin D. And I must congratulate that this is a symposium by IRIS, and they are coming out with a once a week preparation. And that's probably the reason we are going to understand a lot about vitamin D. And that's something which we are going to recognize. Can I have the next slide? So if you look at 100 years of vitamin D, and this symposium has been titled as the Centurion Symposium, you know that the real vitamin D probably has existed from time immemorial. But 1922 was a very key year of vitamin D. And we know that in that year, there was a discovery by Adolf Windaus. And he was actually studying sterols and their connection with vitamins. And one of his key papers, which was published, was on the conversion of sterols in the D synthesis. And that got recognized in 1928 when he got the Nobel Prize. In 1936, we know that McCallum coined a fat-soluble accessory food factor, which we now call as vitamins. And by now, we know that it is known to prevent rickets. But it was in 1936 that Windaus recognized that vitamin D was a specific factor. And that time, the good old days, it was cod liver oil, which was responsible for preventing rickets. And even today, if you ask me, and often Dr. Mittal and me get, tweeted in, tweeted out, that the musculoskeletal impact of D deficiency, namely rickets and osteomalacia, is still the overwhelming feature of D deficiency correction. Of course, there are a lot of non-musculoskeletal impact of D deficiency at a cellular level, which we are understanding better and correlating better. And we are trying to link the biology of vitamin D, the deficiency of vitamin D, and the disease of vitamin D in a much better granularity today. It was much, much later in 1963 that the vitamin D got into recommendations on guidelines. And the first people to recognize them were the pediatricians. And the American Academy of Pediatricians Committee on Nutrition began recommending D supplementation for all infants. And I think even today, as we talk, I'm very appalled that in our nation, we still get children with neonatal hypocalcemia, and they often land up with seizures and convulsions because of neonatal hypocalcemia, predominantly coming out due to the D deficiency. And maternal D deficiency has a direct impact on infantile D deficiency and neonatal hypocalcemia and convulsions. And that's a very, very strong feature which is there. And obviously, after 1963, worldwide, all health organizations said that they need to have recommendations so that their guidelines on vitamin D intake, when there are so many inconsistencies, which is the right D for the right patient at the right time of that lifespan of that patient. For example, what an infant needs at birth is different from a 10-year-old toddler, is very different from a 20-year-old adult, is very different from a woman who wants to conceive at 30, is very different from a postmenopausal woman at 47, is very different from a senior citizen at 74, and is very different from a centennial who's 100 years old. So obviously the need of vitamin D, the requirement of vitamin D in different times of lifespan in the same human being has different levels of recommendation. And Dr. Mittal, who is our domain expert with us today, has actually been a part of many of these global guidelines from the IOF. So obviously that is where the D recommendations got into place in 1963, which is more than 50 years back, almost 60 years back. But the true biology of vitamin D only started coming up in 1979 and 80. It was basically Strump and his co-workers. We discovered that there are something called as vitamin D receptors, and they are cellular receptors. And these cellular receptors have an impact on the gut, have an impact on the bones, have an impact on the kidney, and therefore vitamin D is a hormone and a vitamin and has pleiotropic effects. And its regulation is very tightly, strongly controlled, and it's something which we recognize very well and very much better now. Next slide. So when we look at a overview, we know that D deficiency is a silent public health emergency. And a lot of advocacy across the world has shown that we know that almost 80% of the population at large is D deficient, and maybe 20% is D sufficient. And if you look at the varied nature of studies of D deficiency in India, almost 40 to 99% of them are D deficient. And most studies might even report a percentage of D deficiency between 70 and 100%. In fact, if you look at the Comprehensive National Nutrition Survey between 2016 and 2018, 14% of preschool children, 18% of school-age children, and 24% of adolescents are deficient in D. So if you look at that and make a simple math, 1 in 5 or 1 in 4 children or adolescents have D deficiency. And that's a very worrying statistics because that is the formative time of the bone forming units and the set points for the thresholds for the bone biology to strengthen the struts of the musculoskeletal system. And if our bone infrastructure is built on a weaker strut, it has its own impact. But today our focus is not the bones. Today our focus is immunology. Today our focus is infection prevention. Today our focus is fundamentally a new normal in an uncertain time of COVIDization. Next slide. So if you look at this journey, what are the levels of D and what is the status of adults of D deficiency? We see that we are either in a red or orange zone. And worldwide, very few countries on planet Earth are actually in the green zones. Next slide. So obviously from an Indian perspective, there is some misconceptions. People across the world always thought that India is a tropical country with ample sunshine throughout the year. So D deficiency is very unlikely. But unfortunately, that's not true. The reality is that we are a D deficient nation and compounded with a low calcium intake, which is very common in India, across all age groups and sexes, it is a reality. So what we think and what we are is a big challenge. So it depends that despite of plenty of sunlight, we have a layer of pollution which is impeding our UV rays. The melanin in the Indian skin, whether it works as a sunscreen, is something which we don't know. And whether the D deficiency is an adaptive phenomenon in the Indian population is not something which we know better. So these are research questions. But the clear documented fact beyond reasonable doubt is India is a D deficient nation when we measure the absolute values of vitamin D. And there is no question on that. And our musculoskeletal impact of that is well known. And our non-musculoskeletal impact of that is also well known, at least in cross-sectional data, in prospective data, in retrospective data. These things are emerging and we are understanding better about the D deficiency in the Indian population despite of plenty of sunlight. Also remember that from the jungles and tribals which we all were as ancestors, we have moved in concrete ghettos and concrete jungles of our own rooms. And in this lockdown times, we are particularly locked down in an environment under close quarters where we are actually having artificial light and we have really gone away from the classical UV light. Though the pollution in the last 4 months has definitely come down, and probably the UV rays might be much better now in its penetration on the Indian skin, which is a good research area to look at. Clearly, we know that we have been indwelling human beings now, mainly living in concretized ghettos with less and less of sunlight, and we are D deficient. Next slide. So obviously, we have sunlight as a source. And as I told you, on exposure to sunlight, our ultraviolet B ray wavelengths, which measure between 290 to 315 nanometers with a shadow smaller than your height, will support desynthesis. So shadow taller than you cannot produce vitamin D from the sun, and a shadow which is shorter than you can produce some amount of vitamin D. And therefore, if you look at the timing, what is the right time to be exposed? This has been timed between 11 o'clock and 1 o'clock or 3 o'clock. And that is probably the time when maximum D is made. And that is the time most of us are either work bound or home bound and unlikely to be out, because that is a different timing. I hope that is a simple graphic which will make this point well illustrated. Next slide. Obviously, when it comes to the pleiotropic effects of vitamin D is not a simple vitamin. As I told you, it is an endocrine hormone, and it has a lot of impact on different parts of our system, including immunology and infections. Whatever we consume from fatty fish, fortified food, vitamin D supplements, or sunlight exposure at the right time for the right duration, or whether we have the right VDR receptor polymorphisms or our liver enzymes like CYP27B1, we clearly know that the 125 OHD3 clearly has an impact on our cells which protect us from infection, namely the macrophage activation system, namely the polymorphonuclear neutrophils, mainly the various cells of immunology like the B and the T cells. We also know that D has a very important permeasive role and an important upregulatory and downregulatory role in autoimmune diseases, whether it's rheumatoid arthritis, whether it is various inflammatory bowel syndromes, the macrophages, the neutrophils, the various killer cells, the NK cells, the T regulatory cells, the CD6 cells, the B cells, the T cells, all of them are impacted. So whether it is autoimmunity, whether it is infections, having the right D at a cellular level is extremely important for intact immune function. And we know that our senior citizens have some form of immunosenescence. And we know that D is a very critical micronutrient, a vitamin, a hormone, which has a cellular impact on keeping our immune cells intact and therefore make our body more robust to fight infections better. Next slide. So obviously, vitamin D has actually a role in two types of immunity. One is innate immunity, which we are born with, and other is adaptive immunity, which we acquire. And we clearly know that our cells of immunity, which are the lymphocytes, have some action. We clearly see there are toll-like receptors, and we have the T helper cells. But let us look at the innate immunity. In innate immunity, we know that if the D levels are low, then the DC maturation is weaker, the differentiation is robust, the bacterial killing is robust, the cytokines and antigen presentation is weaker. So D deficiency makes us more vulnerable because our monocyte macrophage system is weaker and we are not as efficient from the biological standpoint to actually attack our enemy better. And we make less cytokines and whatever is the microbe which is presented, the antigen presentation is weaker. So that is the impact of vitamin D from a research standpoint on innate immunity. But the adaptive, the acquired immunity is something very, very crucial and important. Now, in the adaptive immunity, our main cog of cellular immunity are the T cells. And as I told you, there are T regulatory cells. T regulatory cells make the T helper cells. And if we are able to get the right T helper cells at the right place, and vitamin D upregulates the T regulator cells, we can actually fight infections better, fight autoimmune diseases better. We also know that one of the key cogs, which Professor Kachru, who is an Indian scientist at Harvard, has researched, T17 cells have a direct impact on inflammation and autoimmunity. In fact, Dr. Vijay Kachru has done work to show that multiple sclerosis has a direct impact on Th17 cells, and is an Indian scientist who has migrated to Harvard, who lives in Boston now, to show that the Th17 has a role with vitamin D deficiency and can upregulate autoimmune status. So if you get multiple sclerosis, which is a classical autoimmune disease, you can have an impact. Then, of course, the Th2 cells have a direct impact on antibody production. And we know that it can actually, if there is not adequate or sufficient vitamin D, we actually will have a challenge with Th2 cytokines, which are the good cytokines, and the immunoglobulins will be lesser. So remember that if your D is deficient, you will make less antibodies and you will make less Th2 cytokines. But if your D is sufficient, then you will upregulate and make good cytokines. The main cell of the T cell system is the Th1 system, which is the T helper cell 1, which is a cytotoxic T cell. And that is the killer T cell. And they make those Th1 cytokines, which are the killer cytokines like IL-6, TNF-alpha, IL-1. And these cytokines get down-regulated with D deficiency. So clearly, whether it is the toll-like receptor on the dendritic cell, which is the key cell of innate immunity, or it is the T cell, which is the key cell of the adaptive immunity, you can clearly see that the D vitamin has a clear impact on each and every aspect of immune protection, immune regulation, and immune adaptation. Next slide. So clearly we know that the vitamin D and immunity, the vitamin D signaling in the context of innate immunity has a focus on the monocyte. And more data is coming that when we are exposed to various immune challenges, it could be as simple as a common flu virus or a coronavirus or a chronic inflammation or even a pre-neoplastic cell, a cell which is likely to multiply. We know clearly that there is a lot of epigenomic programming, and our monocyte pool, which is made up of monocytes, macrophages, dendritic cells, they have a huge impact on what actually will come out. What would be the first response? For example, when you have an exposure to a virus, when you have exposure to a chronic state of inflammation, or maybe a pre-neoplastic mitotic condition, there is an impact. And one of the key regulators in modulating effect of this epigenome is vitamin D. In fact, vitamin D is now established beyond reasonable doubt to alter multiple levels of the programming process. If we stabilize epigenomes of the subtypes of monocytes, of macrophages, of dendritic cells by vitamin D, it can prevent or delay onset of common age diseases. So this is all in the experimental immunological biological pool, but it has direct impact on human lives in the next 2 decades. In the next 2 decades, you will see a lot of focus on human monocytes and the impact of vitamin D signaling on the epigenome modulating effect, particularly on the monocyte, on the macrophage, and on the dendritic cell types. And that might have a huge role in delaying a lot of non-communicable diseases, autoimmune diseases, and even neoplasms. So obviously it has a potential to prevent or protect. The experimental data is extremely exciting that you can modulate what you are born with. Remember, innate immunity, which is our monocyte, macrophage, and dendritic cell subtype pool, is what we are born with. And can you program it to make it more efficient? And what is that programmer? What is that amplifier? So the programming, epigenomic programming, or the amplification of our monocyte pool can have vitamin D as one of its amplifiers or modulators. And therefore, vitamin D can have an impact on innate immunity. And therefore, maintaining the right D level in these times of new normal might have a crucial role, not only in just preventing A or B viral disease, but maybe on chronic inflammatory diseases or pre-neoplastic cells. Next slide. Now let us look at adaptive immunity, because it's just not important to recognize the role of the innate immunity. We know immune cells like macrophages synthesize and respond to the active vitamin D, and these functions further are enhanced by challenge to the immune system. We also know that vitamin D stimulates the innate macrophage immunity by enhancing the bacterial killing and modulates the adaptive lymphocyte immunity, particularly T lymphocytes, to minimize inflammation and autoimmune diseases. D deficiency or insufficiency is associated with a compromised immune function, and therefore D deficient individuals are more susceptible to diseases like tuberculosis. They are more susceptible to autoimmune diseases, including type 1 diabetes. And if you look at this graph or graphic which is put out here, here you can see a mature macrophage dendritic cell and how the immature dendritic cell or monocyte is having an impact on the mature dendritic cell or macrophage, and how the resting T cell, the T regulatory cell, the activated T cell, the activated B cell, at each step of this immunological process, you can see active vitamin D has a pleiotropic role, has a permeasive role, has a mechanistic role from a mechanistic standpoint to ensure that we are protected from an immunological and a biological mechanism. Next slide. Now, there are been a lot of guidelines on vitamin D in COVID, whether it is the American Society for Bone and Mineral Research, the American College of Endocrinology, the National Osteoporosis Foundation from the US, the International Osteoporosis Federation, the European Calcific Tissue Society, the US Endocrine Society. Clearly, we know a couple of simple things. We know that when the outdoor activities are reduced, sun exposure is blunted, the vitamin D will go down in the pandemic. As it is, we live in a nation like India, which is already D deficient. Most adults can safely take around 400 to 1000 IU to keep the D levels in the optimal range. And a reasonable amount of the work which I just showed you of some top-notch elegant scientists have shown that active vitamin D has a clear impact on maintenance of adaptive and innate immune responses. And therefore, there is a clear need of D supplementation in the COVID pandemic, which many of us are actively looking at. In fact, some people have used a MAT protocol where they have given 3 mega doses of 60K for patients who are coming in with COVID, and they have studied their impact, even without looking at vitamin D. There is some data on that. Next slide. So, what is the role of vitamin D in COVID-19? Very clearly, there has been some very old work, more than 30 years back, both in pediatric and adult population, stating that, and this is all observational work, started as anecdotal work, then became observational work, to show that D deficiency has an increased risk of acute respiratory infections. So lower the D, the more is the susceptibility to get viral acute respiratory infections. And a reasonable meta-analysis of all the published data till date has shown that if you supplement the vitamin Ds, there is prevention of acute respiratory infections and it has a protective effects. So now we have some data. So 3 decades back, the data started emerging that lower the D, more is a susceptibility to viral acute respiratory infections. And now we have a meta-analysis of pooled data from clinical trials because we live in an era of evidence-based medicine to suggest that supplementation might prevent the prevention of acute respiratory infections for protective effects. So the underpinning hypothesis in COVID particularly, which is the coronavirus, which is the RNA virus, SARS-CoV-2, is nothing but a imbalance between an overactive renin-angiotensin system in the lung via an ACE2 downregulation, which is followed by a lot of hypoxia in the type 2 pneumocyte, a lot of inflammation, clearly supports the role of vitamin D in these individuals. Next slide. So clearly the link is getting slowly but certainly established. This is a slide and Professor Mittal recently did for the Endocrinology Society of India with the European Society of Endocrinology. Very nice educational program. And we clearly know now that the vitamin D and COVID-19 is linked. We know innate immunity is what you're born with. It is pre-built and it relies on the constitutive expression of the pathogen recognition. So it is like our radar. It is like our body's warning signal system. It is like our weather radar. It is like that Doppler radar, which recognizes good, bad, and evil. And in that radar recognition system, you need the right wires at the right place. And for those right wires at the right place, vitamin D is the key cog. So let us look at the quadruple impact of vitamin D. Number one, vitamin D enhances the defense by enhancing antimicrobial peptides. One of the key such peptides in viral clearance and viral destruction is cathelicidin. And we clearly know that if there is good amount of vitamin D, cathelicidin levels are appropriate, there is a better viral clearance and destruction. That is the first cog. The second cog in the quadrat is D acts by neutrophils and macrophage activation. And therefore the pathogen clearance or the microbe clearance by the dendritic cells, as well as the adaptive immune response initiation, is much better by the vitamin D. Third, the adaptive immune system initiation, when it is initiated and activated, the T helper cells make a very specific and mount a very powerful response on the invaders or the invading microbes. And the fourth and the most important cog is the deadly complication of the cytokine release syndrome, which is popularly called as cytokine storm, curtails the chronic innate immune response by different mechanisms. We know that D deficiency will cause a lot of downregulation of the toll-like receptors. We know that it will directly, if there's a deficient D, there will be inhibition of TNF and NF kappa beta, and there will be downregulation of the interferon gamma signaling pathways. So obviously, if there is a curb on the innate body responses, like the toll-like receptors are down, so the toll gate is closed, the TNF alpha is blocked, the interferon gamma production and signaling is blocked, obviously you will get cytokine storm. So obviously the milieu to make a worse outcome is amplified by D deficiency, is an hypothesis people started working with as COVID came in. And after 6 months of COVID, we now have some data, some granularity to suggest that this link is likely to be robust and more scientific and evidence-based. Next slide. So obviously, as I said, cytokine storm is devastating. And the pulmonary cytokine storm is the major cause of morbidity and mortality in COVID. And it is all because the innate immune system has a too much of excess of pro-inflammatory cytokines. And these pro-inflammatory cytokines and chemokines lead to a signal to an adaptive immune pathway. The more rapid the virus will replicate, it will release a lot of inflammatory cell infiltrates, a lot of pro-inflammatory cytokines like IL-6, TNF-alpha, IL-1, and a lot of chemokines, including activation of a procoagulant and a thromboinflammatory state, leading to an ARDS and a COVID coagulopathy. And clearly we know that this is something where cytokine storm has an impact. Next slide. So obviously, if you look at the 20-country European data and look at the correlation between cases per million population and the mean level of vitamin D, a significant simple plot shows a significant negative correlation has been observed between mean vitamin D levels and the COVID cases per million in 20 European countries. So better the D, better is the R value, and clearly there is a correlation. So if your D levels are better, your COVID outcomes are better. If your D levels are lower, your COVID outcomes are poorer. Next slide. This was a study done in 780 Indonesian patients with confirmed COVID. And you can see that the COVID-19 death rate by vitamin D levels is correlated here. Normal, insufficient, deficient. And you can see here, as somebody moved from normal, which is only 4.1% of the Indonesian population, to insufficient, which is 87.8% of the Indonesian population, to deficient, which is 98.9% of the population, there was a correlation with mortality. Next slide. So obviously, avoidance of D deficiency to slow the COVID pandemic was something which was published by Martin Kolmer in the BMJ Nutrition, Prevention and Health. Clearly, we know individuals with high age, excess body fat, dark skin tone, or risk predicting genetic variants are linked to extra vitamin D, particularly in dark months of winter and spring. The higher number of COVID deaths in North United States as well as the European states clearly support the hypothesis that the D deficiency in the African Americans have a disproportionately high risk. And therefore, preventing the D deficiency at any time of the year must be pursued in the earnest, particularly in people who are most vulnerable, because this is a very easily identifiable common characteristic. So this is something in the COVID pandemic, the D deficiency has become extremely pertinent and relevant. Next slide. So obviously, the how much to supplement, has been a treatment duration dilemma. This is the data which is published from the Indian subjects, and very clearly in Asian Indians with 8 weeks has been shown almost 12 years back that if you give D supplementation in chronic vitamin D deficiency states, it would normalize the D levels and subsequently it will be reduced to half. So a quick fix is not appropriate for the right optimal D level. Because in a quick fix like this, the D levels come back to half their normals within 1 year. And therefore, sustained, durable, long-term D supplementation over a period, can you go to the previous slide, is very, very critical. And it's all about giving it every week, giving it at the right time, giving it and maintaining the right amount of optimum D. Because it's important, sometimes people are not ready to take it every day. Sometimes they may take it every week because we need the right amount of vitamin D at the right time on a Sunday at 11 o'clock. Next slide. So a weekly dose of vitamin D resulted in a greater increase of vitamin D than a monthly administration. And there's data to show that. Because vitamin D is a fat-soluble vitamin. It has a long half-life. Daily dosing may not be necessary. a weekly might be good enough. Also remember that the gut compliance, the absorption is much easier that way. Next slide. And we have data to show that. This is a slide and graph which shows that. So if you look at the endocrine practice recommendations or the Institute of Medicine recommendations, in healthy adults, 5 months of ingesting 1000 IU of vitamin D neither caused hypercalcemia nor increased the urinary calcium excretion, which is the most sensitive indicator of vitamin D intoxication. Because D being a soluble vitamin, we always have a fear that can it increase the urinary calcium output or can it cause hypercalcemia? Can it cause detoxicity? And probably 1000 IU per day is the safe normal of vitamin D. And if you give it once a week, probably it is optimal or ideal. Next slide. So are there RCTs? Because we live in an era of RCTs. And this is an RCT which shows very, very clearly it compared daily, weekly, and monthly administration of vitamin D. In this prospective randomized control trial, it looked at the safety and efficacy of daily dose of 1000 IU in group A, once a week 7000 IU in group B, and monthly 30,000 IU in group C. And there were 64 adult subjects of D deficiency were included. They were supplemented for 3 months. And we can look at the dose response curve of the 25 OHD levels were statistically equivalent in each of the groups. And clearly the outcomes showed that they were all very tangible and similar. Next slide. And this is exactly the data which I told you. Next slide. So clearly this study showed us that 1000 IU of daily equivalent dose of D for 3 months in a D deficient population significantly gets you the right mean of the D levels you need. Due to the long whole body half-life of 15 days of vitamin D, a daily dosing may be unnecessary and weekly dosing may be ideal, is what the author suggested. And in this study, a weekly 7000 IU or a monthly 30,000 IU dose for 3 months showed that it was safe and effective. Next slide. So obviously, there is some more data of looking at 7000 IU of vitamin D per week for 12 weeks, low increases the vitamin D levels from 12.7 and 13.1 respectively. So clearly a statistically significant value. Next slide. In growth hormone deficient children. So clearly, I think what was the whole goal of this presentation? That we are a D deficient state. And an effective strategy to prevent vitamin D deficient state in adults is to administer 50,000 IU of D once a week for 6 to 8 weeks. We have most of us use 60K, 60,000 K, because you know that India 50,000 IU is not available. To prevent recurrence, a monthly maintenance dose or a daily administration of 1000 IU is good enough. The recommendation is 600 to 1000. Though in certain individual cases, we might need up to 2000 K. Clinical data suggests that a daily or weekly administration of D has a greater impact on D than a monthly administration. Because we know the long half-life of D is 15 days and the weekly administration of 7000 IU might be equivalent to 1000 IU of vitamin D with equal efficacy or safety. And if you feel that you need to give your patient 2000 IU, then maybe you can give 2 tablets of 7000. So weekly dosage gives you that convenience rather than the daily dosing and improves compliance in a larger footprint. Next slide. So obviously the 7K or 7000 makes your D sufficient quickly and maintains you sufficient. It is a better compliance. It is a better balance of safety and efficacy. Definitely has an immune modulating role, particularly in COVID times. Probably is a metabolic regulator. Definitely has a musculoskeletal impact beyond reasonable doubt. And pleiotropic benefits week on week will be established in times to come. Next slide. So thank you so very much We are in a new normal. I might have overshot my time, Viraj, but I think I just wanted to make it very simple and straight that it's a very important thing. And I'm thankful that you thought of this topic on a Sunday. I did not know that this is 100 years of vitamin D. So I was frankly not aware. And I'm very happy that you chose a time which is 11 o'clock, which is the peak time of the UV rays. And if you really do that in the right way on a Sunday, it is very nice. Thank you so much.
Thank you, Dr. Shashank. I would now like to invite Dr. Amrish Mittal to share with us his perspectives on whatever has been presented, plus, of course, beyond that. As I said, he's a global expert on vitamin D and including his own data on this particular topic. Yes. So you'll need to unmute.
Thank you, Viraj. Thank you, Shashank, for a fairly exhaustive coverage of vitamin D in areas which are not normally discussed, and that's the nice part because we always discuss parathyroid and vitamin D and bone health, but you've covered an area that is relevant to today, that is very relevant to today, and the role of vitamin D in non-skeletal effects, particularly in the context of inflammation, infection, etc. So I think that's important to understand, and I'll just make a few points here. I'll try and summarize and synthesize what Shashank has said into some more takeaway points. So the first thing is that when we look at vitamin D, there are two silos. One is vitamin D, the endocrine, the hormone, as we all have studied through decades about the formation of vitamin D, its activation in the liver, its subsequent activation in the kidney, its regulation by PTH, its feedback with PTH, and now FGF. So that is the endocrine aspect of vitamin D, which is well established, what we call the traditional effects of vitamin D, its role in absorbing calcium and preserving our bones is beyond any discussion. I mean, obviously there are fineries even there which are being worked out, but there is no confusion about this action. So that is the endocrine vitamin D. Then there is an intracrine vitamin D, which is exactly what Shashank alluded to here. The intracrine vitamin D is the formation of 125 within cells. Okay, the active form of vitamin D not coming from the kidney, as the usual process in our body that is circulating 125. This is cellular 125 that Dr. Joshi highlighted so nicely. That cellular 125 is formed within cells. And in this context, for example, the antigen presenting cells, like the dendritic cells, as he alluded to, are macrophages, where intracellular formation of 125 is a key method by which they combat infection, right? Whether it is antimicrobial, whether it's antibacterial or antiviral, the truth is that these cells, the antigen presenting cells, the macrophages and dendritic cells, require to make 125. That's a key ingredient. Now that 125 is formed intracrine, but there is also a contribution of circulating 25 hydroxy vitamin D, which provides the substrate for that action. So that is the overlap between endocrine and intracrine systems. Circulating vitamin D, 25D, that's fine. We know the PTH axis. And then that also contributes to the formation of intracrine 125. And that is the basis of all the innate immunity and impact on adaptive immunity via cathelicidin and defensin B, whether all that has been discussed. So we won't. So this is one aspect we need to understand. There are two things in vitamin D, right? Traditional understanding and intracrine understanding. So the second aspect I thought, which is important to emphasize is, and I made these notes as Shashank was talking, was about the nutrient aspect versus the pharmacological aspect. Okay, so again, there is very little controversy about nutritional effects of vitamin D. One may go on arguing till the cows come home about the correct level that is required. But there is no doubt that vitamin D nutrition is important for us. It's of course important for our bones, and it's also important for so many other processes within the body. So which means that if you have adequate vitamin D, nutrition, you are actually protecting your bones and muscles, but you're also very likely protecting yourself to some extent, at least, from infections, particularly respiratory infection. Data on respiratory infection is there that people who are severely deficient have more severe more likely to get, and more severe respiratory infections, poorer outcomes, right? So that is the preventive part of D. There's another part which is much debated, and not the final answer is not out yet. So that is whether vitamin D has a role in suppressing the cytokine storm. We know, as Shashank pointed out, that COVID-19 excites an exaggerated responses causing all this mess. Hence, all the dexamethasone, this, that, all that story. So, what is the role of vitamin D there? Do we require much higher doses of vitamin D there? I don't know. No one knows, but that's an area. So I recently wrote a review on this in osteoporosis sarcopenia, where we called it, Manju Chandran is the first author from Singapore, dousing the fire or averting the storm. So one is dousing the fire, that is you preventing the fire from gaining ground by having adequate D levels, maintaining your immunity. Other is, if there is an infection and a storm coming up, if you have adequate D levels, you will probably be able to fight them better. The second part is not as well understood as the first part. However, in COVID-19, as again very succinctly pointed out, studies dedicated to COVID-19 are very few yet, because the disease is so new, and it may just be one of the factors among so many factors that we are looking at in terms of outcomes of COVID-19. So it, however, makes sense. It is common sense, that maintaining at least adequate level of vitamin D in our blood will help us combat any infection, help our immunity, and may even help us fight the storm. And therefore, maintaining a level of 20 nanogram or above is definitely, you cannot go wrong if you are between 20 and 40 nanograms. And some labs still give 25 to 100 as normal. I don't know what's happening, but nanograms, 20 to 40 nanograms is a good D level. Within that, endocrinologists may argue like crazy about 20 versus 30, this, that. But for practical purposes, if we maintain levels between 20 and 40, we are pretty safe. Above 30 is even better, but don't have to go crazy about it. 20 to 40 is a good level. So to achieve that level, what is it that we require? And that's the last part of my comment, the challenges in vitamin D in the clinical part. We already heard why we are deficient, and a lot of us have deficiency, and urban Indians clearly are deficient. Urban office going Indians are deficient. Urban middle class Indians are deficient. Doctors are deficient. So this class, maybe in the cities, the rickshaw puller, the manual construction site worker is not deficient. They are in sun all day. Despite the pollution, enough reaches them to make at least adequate vitamin D. But the truth is that bulk of us are. I mean, any study from Delhi, Bombay, Lucknow, Varanasi, you name it, shows the same thing. So it makes sense to correct that though. What should be the supplementation? Let's say a typical level in our population is 10, 11, 12 nanograms. Quite common. If you get your patients done, checked, you will find many in that range. Remember, 1 nanogram is 2.5 nanomoles. So if you lab is reporting in nanomoles, don't get confused. It's 2.5 times. So 10 nanogram is 25 nanomoles. So if you even take 10 nanogram as a marker as a cutoff for severe deficiency, there is no controversy worldwide. 12 nanograms or 10 nanograms, So you clearly will have a substantial proportion of your patients even now in that zone, right? Now, when we want to have these patients reach 20 or 30, right? You want to add 10 nanograms, 15 nanograms, 20 nanograms to the level. So if you're adding 10 to 20 nanogram to the level, you can only be safe. You cannot go wrong. And 1000 units will roughly increase your D by about 10 nanograms. That is the key point. 2000 will roughly increase by 20 nanograms. So if you're going up to 2000 units a day, you can never exceed 40. It's highly unlikely, or maybe you exceed once in a while 42, 44. There's a lot of variation, but you will not. So if you're keeping your intake between 1000 to 2000 per day, or the equivalent amount weekly, you are safe. 90% or more, our own data has shown that you'll achieve optimum levels. So we published a few years back that, even once a month, 60,000 works, but probably there is more emphasis on weekly or daily doses now. So if you do that, then if you use this, not the 400, 600 that is recommended by the US and other societies, because their baseline levels are 18, 20, 24. Our baseline levels are 8, 10, 11. So it does not make sense to apply that blindly. So all that I have to say is that it's important that we use the correct doses. What is happening is, like in D deficient state, sometimes you use 60,000 once a week, as again pointed out in the summary slide by Shashank, that you use for 6 to 8 weeks and then give it like then a maintenance dose. So only those who are severely deficient require that. If you're not even measuring, you can use 1,000 to 2,000 with the eyes closed. You don't have to measure. If you can, it's all right. If you can't, it's okay. You cannot go wrong with these numbers. If you do use the higher dose initially, which is fine, then you have to use a maintenance dose. The lack of maintenance dose, treating vitamin D deficiency like an acute disease, giving high doses 6 8 weeks and then shutting off, again coming back next year with the same level, is tricky. Therefore, it's important, and compliance with the daily doses is a challenge. And therefore, if one can have an option of the correct weekly dose, as is being tried here, that would be a great option to have for us. Because people are used to weekly doses. Somehow in vitamin D, they talk of weekly dose only. And when you tell them daily, said, how come won't it be excess? They don't see that the weekly dose is 60,000 and the daily dose is 2,000 or something. So, but a weekly dose of the correct, a weekly a pill with the correct dose will be a very useful addition. So that way, I'm quite happy this is happening. You could use one, or as Shashank said, you could use two per week, and you're in the zone where you'll be always comfortable. I think those are my comments, and then we take the questions.
Yeah. Thank you so much, Dr. Mittal. In fact, I was intrigued when you said about intracrine. So in that connection, I just wanted to check with you. Since vitamin D is lipid soluble, so it would get stored in adipose tissue. So would it exert a local intracrine effect even there, especially in states such as pre-diabetes, like non-alcoholic fatty liver disease, where there is an adiposopathy? So would vitamin D would help in that?
It's not clear. It's not clear if storing vitamin D in your adipocyte really makes a big difference. It is likely that it may reduce the release of cytotoxic or cytokines from visceral adipose tissue. It's possible. But that's another story. We're going on to the metabolic disorders now. But I think that's still not 100% proven.
And sir, the other question that some doctors ask is in terms of, see, on the one hand, we have many Indians who are vitamin D deficient. We know of this correlation between COVID-19 severity and levels of vitamin D. Yet in India, if you look at mortality, now I know it has crossed 50,000, but still it's not as
it's not high.
As so that's what they have not been able to understand. That
that's absolutely true. The case fatality rate in India is still, we are blessed. It's still lower than most other countries, and I think vitamin D cannot explain that. There is no doubt. There are numerous other factors that have been called on, including young age of population, including immunity to other viruses. There are so many factors, but we don't have a final answer on that yet. I'll give you an example. The BAME story in UK has got so much ground. The Indian, South Asian doctors who are involved, or South Asian individuals who are affected by COVID, are more seriously affected than as compared to the native white Caucasians. Now there you have actually people of South Asian descent being worse off. And in India, if you look as a whole, people of South Asian descent are better off than the English outcomes. You know what I mean? So there are things within the environment which you don't understand as yet. So, but within that band of people, those who are D deficient are more likely to have poorer outcomes. Although this is not conclusively proven for COVID-19 yet, it's very, very likely.
Thank you, sir. I think now what I'll do is just go through the questions. Already 44 questions have come, but I won't ask all 44. I'll just quickly ask, and then any one of you can answer. So the first question is from Dr. Anand Shankar in Patna. Any correlation between vitamin D and adiponectin level?
Shashank, you want to take that?
Yeah, I think, so as again Dr. Mittal said, and what you asked on adiposity and adiponectin, at a cellular level, probably it has a permissive impact on adiponectin also. But that is at the local intracrine or paracrine effect. But at a biological level, if you ask me a simple question, no. There is no real direct impact on many of these cytokines. And we need to do much more objective data. So low adiponectin definitely has a negative outcome. So you need to build the right adiponectin, but that is more in the obese population. And you know that obese population will actually store vitamin D much more. But these are, as I said, areas of research. Do not translate cellular or intracrine impact of vitamin D into clinical care ASAP. Those recommendations are forthcoming and they will take some while to come. Do not be jumping the gun here and saying that, okay, I need to improve my adiponectin level, I will give vitamin D. The answer to that is no. But these are exciting times. We might get better outcomes research in the future where we might have these data coming up. Currently, all we can say is that it has a protective role from an immune standpoint, from both innate and acquired immunity. So that role is clear cut. But on specific adipokines like adiponectin, the data is there, but that data is in experimental realm and cannot be a recommendation.
Dr. G. Rajgopal from Kurnool is asking, what is the preferred preparation for supplementation in a COVID-19 patient? Should it be cholecalciferol or 125 dihydroxy vitamin D?
So you want me to take that?
Yeah.
I think that's a very interesting question. The the one point that I wanted to discuss will now be brought out is that the fact that the data on the storm part will probably be stronger with the 125, but no one's really looked at that. So we would still use cholecalciferol. My contention or my suspicion or doubt in this is that if you are suddenly correcting D level in someone who's admitted for 2 weeks or 1 week for COVID, I don't know whether we'll get any benefit at all or not. We should probably just do it earlier. I mean, I doubt it very much if you're adding vitamin D to the mix of, all the antivirals and all the dexamethasone. How much role it will play is remains unclear because acute correction, it's a chronic condition. So maybe in the acute situation, using calcitriol 125 may be very interesting because that has a different direct action. But I think that's not been looked at. So it's a great question. It's a great question.
Dr. Santosh?
So
Yeah.
one comment on that
Yeah.
is that what Dr. Amrish Mittal said is very correct. But this MATS protocol, and the Michigan Henry Ford system, which Dr. Mittal knows very clearly, they actually looked at two mega dose trials. One was IV vitamin C, and second is a mega dose of vitamin D, where they gave cholecalciferol 60K or 50K, three doses consecutively. Their idea was to correct rapidly the D deficient level. So when somebody walks in with a COVID, immediately give three doses, 1 day at a time over the next 3 days, so that you can get that level a little quick and fast, rather than sort of, because you see whatever impact has to happen actually has to happen in community, and we are a susceptible community. So in a susceptible community, people who are non-infected, having them better vitamin D levels, like Dr. Mittal said, the average levels are around 18 in the Caucasian population, or 20. In Indian population, they are around 10. So if we are able to give them the right D and maintain that level, then their susceptibility to COVID and ability to fight COVID is much better. So when they come into the hospital, the pre-hospital D level will be better. Unfortunately, Dr. Mittal didn't mention his data, which is unpublished, and I can tell you also, among more than 600 cases we have seen, most patients with COVID have again D levels below 10. A good 62% of them had D levels below 10, which also indicates that D levels might have a pleiotropic impact, but may have a direct impact on vulnerability and susceptibility to COVID. But as I said, it takes still a long way to understand this.
So we are now looking at Shashank at the outcomes of all these.
Correct.
And we've done some additional markers. So let's see. I hope by end of the month we have something to say.
So,
Dr. Santosh Kumar Singh from Patna is asking the role of magnesium for optimum vitamin D activity.
Well, magnesium has a role, we know. I mean, but I don't think it's so direct to vitamin D activity. It has a role on the effects of vitamin D, especially in the endocrine axis. Where you look at hypoparathyroidism and other places where PTH and vitamin D action will be impaired if there is hypomagnesemia, because there is a loop between magnesium and PTH also. But I'm not personally aware of magnesium per se impairing vitamin D activity, especially in the cellular or the intracrine setting.
The other
Only
question.
one quick comment clinically is that if you have an alcoholic, he's likely to be
Oh
magnesium
yeah,
deficient.
yeah.
And there could be an impact, but it's an indirect impact. So just be mindful of the fact that if you have an alcoholic, then be very clear
Sure.
that don't miss out a magnesium deficiency. Beyond a non-alcoholic situation, I would not put too much to it. And alcoholic means a chronic alcoholic, not a social drinker.
Then many people have asked this question about the role of vitamin D in diabetes and thyroid disease. And is it that, every diabetic needs to be given vitamin D?
So if we talk of a role of vitamin D, firstly in thyroid disease, there's no role that is proven. So we can sort of check it. Only thing is that people who are on long-term thyroxine, maybe especially those who are on excess thyroxine, no, and especially older women, we should make sure that they are replete. So they shouldn't be deficient, not because they have thyroid, but also just simply because they are postmenopausal women and they are chronically on thyroxine. Sometimes they may be overdosed. You may be impacting their bones. So make sure at least the calcium D is okay. That's all. But there's no direct relationship. You will find many theories, but there's no direct relationship proven. With diabetes, there is more work. In type 1 diabetes, there's a whole lot of work about prevention of type 1 diabetes by improving vitamin D status. That's another, again, intracrine sort of thing. There's a role of 125 hydroxy D3 in pancreatic islets, in insulin resistance, everywhere. But when you talk of the role of whether every diabetic should be given vitamin D, uh, it is still a question that cannot be answered correctly. But the issue is that if you want your patients to be D sufficient, in your urban patients, most of them will require some vitamin D. And you will be definitely helping their bone, likely helping their risk of infection, and possibly helping their metabolic parameters. So diabetes per se doesn't become an indication for using vitamin D, but you can't do any harm if you use the correct doses.
Thank you. And the other question which lots of doctors have asked is in terms of, this daily 1,000 international units, vis-a-vis if I take just once a week, 7,000 IU. Of course, I also want to make it clear to the doctors in general, because one of the doctors mentioned that some doctors are prescribing both. So obviously we should not do both in the sense, but suppose it's 1,000 IU daily versus 7,000 IU weekly. Would the 7,000 IU weekly be better, or the daily 1,000 IU is fine?
Shashank, going to take that?
I think 7,000 IU should be equivalent, but that's all I can say, and that's what the studies have shown. Amrish?
Yeah, I think it's all right. I think the data that has appeared is about the large mega annual doses, which are not considered so good. There might be some increase in fracture risk, some increase in hypercalcemia, but daily and weekly is pretty good, whichever works for your patient. And if the in general, if the compliance is better with weekly, go ahead with weekly. If you think your patient is happier, there are patients who will say, I only want daily dose, I'll forget every week. Then you use daily. But I don't think in daily versus weekly, there is any, it's only your suitability and your patient's suitability.
Sir, regarding 60,000 IU weekly versus 7,000 IU weekly, is there any preference or any positioning that, what?
So classically, in people who are seriously deficient, especially those who have come with bone problems and those who have a high PTH. Now we are getting into a bit of this thing. Those who have high, one should use a higher dose. One should use 60,000 once a week for 6 to 8 weeks, followed by the 7,000 weekly or 1 to 2,000 daily, right? That is no brainer. The controversy in medical literature is asymptomatic and below 10, completely nothing, just found below 10, which we find in so many of our patients. Whether those people benefit by a higher dose initially and trying to correct, or whether just giving this kind of dose over a period of 3 months will correct them, is that any worse, remains unclear. So you cannot go wrong with the 60,000 dose if you're limiting to 6 to 8 weeks. But you have to follow it up with a maintenance dose. If your patient has symptomatic bone disease and you've studied has a high PTH, go for the higher dose. In the asymptomatic patient who is between 10 and 20 nanograms, you would clearly opt for this lower dose. In the asymptomatic patient below 10, it's a toss up. You can decide. Typically, what I do is those who are below 10, I do give 60,000 weekly for 6 to 8 weeks and then follow up with a maintenance dose. But it's not a rule. There are people who say that even below 10, if you just give 14,000 a week or 7,000 a week, you'll do pretty well.
And sir, is there any...
Viraj, just a quick comment on this, that I agree with Dr. Mittal completely. But asymptomatic people with a normal PTH, if I give 7,000 K ka 2 tablets a week, I think might probably be more physiological
Yeah.
from a simple physiology standpoint, because I don't have anything impacted there. My bone biology and the vitamin adaptation over 3 months is...
So there is that's what I said. So this over 3 month story, you will get good levels with this 7 to 14,000 per week. You'll get very good levels at 2 months, 3 months. It's just that it doesn't happen fast. So if you are, trying to correct quickly, that only happens in those who come with, high PTH, bone pains. That's a different group, symptomatic. Asymptomatic, you have a choice of whichever one you want to use.
So then, is there any role for injectable vitamin D?
Well, I am
No.
passionate about that. No, Shashank has already said that before the question was complete. It's like Dhoni hitting a six before you bowled. So, there's no role. I mean, unless someone has malabsorption, in which case you talk to your endocrinologist or gastroenterologist. There's no way you should be using injectable vitamin D. There's no role.
Any association between renal tubular acidosis and vitamin D, especially Fanconi syndrome?
Well, Fanconi syndrome is a syndrome where it's a totally different story altogether. And there it leads to metabolic bone disease, actually. So you have to correct the whole calcium, vitamin D, PTH story there. So, I mean, obviously you have to correct the D level. And many times, if it's a renal problem, then you may have to use calcitriol there rather than native vitamin D.
And I think in view of the time, last question, is there any role at all? This doctor is asking whether if you give vitamin D, does it do something to that PD-1 receptor on the immune cell? Is it enhanced in any way?
Yes, it has some role, and it can have a very good impact. But as I said, all these are biological questions in a cellular lab, and they have to be translated into human labs and human trials. Right now, also, we are getting cross-sectional data of a Max system or a Lilavati and a Joshi clinic system. But, this is all cross-sectional and we are trying to correct it. But what you are talking about is something in biological labs exists. And the data on vitamin D and the publications on, the cellular 120 OHD is very huge. In fact, a net impact, if you do a PubMed search, even of vitamin D and COVID, which I did yesterday night. Okay, Viraj, in just last 4 months, okay, I got 3,800 hits, which is, like, according to me, pretty huge.
Yeah.
And it is pretty large, and most of the papers published are all in the laboratory space. But to translate in laboratory space into actual clinical space, there is a gap. I'm sure Dr. Mittal will have the last word on this.
No, I think you're absolutely right. I think for us clinicians, all of you are clinicians. For us, what matters is that we have to try and maintain adequate D levels, number one. Number two, for a definitive answer, we will have to wait for a proper intervention trial in COVID showing an impact both on the risk of getting infection, which is a very difficult study, by the way. It's a population-based study where one group gets vitamin D, other group does not, and follow up, they may not get COVID at all. Based on so that is a larger study in a population, like countrywide study, something like that. That will make a difference, but it has to be intervention. It cannot be a correlation. The final proof has to be an intervention like we have for rickets, osteomalacia. That kind of proof has to come. That is still lacking. What we see intracrine, the numerous, it's very fascinating. But what is the role of what we take, orally in balancing that intracrine or affecting is, we'll need to understand more. So.
And sir, just one interesting question. Is there any role of calcitriol in patients taking hydroxychloroquine? Because apparently it reduces one hydroxylase, which is useful in vitamin D intoxication.
I think you're just forget it.
Can we just now see hydroxychloroquine? Actually, if you ask me, the best micronutrient which is married with it is zinc,
Yeah.
not vitamin D. Let's be very transparent on it. So
Yes.
don't. And also, I think there's too much talk on hydroxychloroquine. So I think it's better that we avoid this for some other day, because we know for sure that hydroxychloroquine, its impact is currently unknown. If you ask me very honestly, it's an unknown entity. It might have some role. I'm not denying that role, but I think currently the more and more data which has come is negative and less is positive, except maybe for pre-exposure prophylaxis, which also is being looked at again. So except for that, I think don't put. And I think calciferol is not an easy substance. Can cause hypercalcemia.
Yes.
It's to be used mainly. It was a nephrology medication. Correct me, Amrish, if I'm wrong.
Yes.
And people misuse it, I think, and it needs a lot of caution.
So exactly what I was trying to emphasize. 125 or calcitriol is a drug. Cholecalciferol is a nutrient. So that's a medication. You can't prescribe it like, without, you need to really think and then prescribe.
Thank you
So
very much. I think both of you all have given beautiful perspectives overall on vitamin D, and particularly as far as immunity and COVID-19 are concerned, including the dosing regimen. As Dr. Amrish Mittal rightly said, it's about ensuring that we are sufficient. I'm not really talking about now Atmanirbhar or self-sufficient, but I'm talking of the fact that we should be sufficient in vitamin D. And if you can get it from the sun, if you can get it from food or fortified food, great. But if we can't, then I think we need to supplement. And then, of course, there's 1,000 IU daily versus 7,000 IU weekly. Perhaps the weekly dose may promote compliance and may be the best balance of efficacy, safety, and compliance. We don't really know, but it's definitely another good option that is available for your patients. So thank you very much. Please stay
thank you.
safe. Please stay healthy and protected, because as I always maintain, it is doctors who need to first protect themselves, because the COVID-19 task force has clearly said, 33 times higher risk. So therefore, please protect yourselves and obviously your patients as well. Thank you so much.
Thank you, Viraj, and
Thanks a lot.
thanks a ton. And stay safe and self-protect.
Yeah, thank you.
Bye.
Bye.
Bye, Amrish.